Thank you, Dr. Nomdi, for giving me this opportunity. Well, I will be presenting macular hole in different scenarios. Starting with a simple macular hole, after doing a thorough vitrectomy and PVD induction, staining the ILM with a BVG, and with the pinch and peel technique, proceeding with the ILM peeling. It's always better to peel as much as possible. I prefer to do it from arcade to arcade, because when there is a recurrence, we are left with another repeeling. So I want to prevent that. Once we are through, and if it is a simple macular hole, we drain it. Well, we do a fluid direction. This is a case where there's a large macular hole. Along with the macular hole, there was an epiretinal membrane complex. Once we stain it and peel, what do we do? A little bit different compared to the simple macular hole. We actually drain from the edges of the macular hole, which we don't do it in a simple macular hole. And in this case, with draining from the edges of the macular hole, it was actually closed on table. You can see the hole being closed. Now, nowadays, what we do, instead of draining from the edges of the macular hole, we do a technique called inverted flap technique. As you can see, we have stained the ILM with a BVG. And then instead of taking the ILM in total, we keep one edge attached to the macular hole. And once we have done it, we do concentric peeling. Make sure that we peel it from arcade to arcade. You can stuff it or you may not. This multi-layered flaps will actually act as a scaffold on which the retinal tissue will grow. So stuffing is not mandatory. Once we do it, we do a fluid air exchange from the disc and nasal to the disc. Now, this is a slight variation of doing an inverted flap technique with some modification. After we have peeled and kept the ILM free flap on the macular hole, sometimes it doesn't happen how we want it to happen. So here in this case, there was a free edge and the macular hole, the ILM, the flaps of ILM was on one side of the macular hole instead of covering the macular hole. So after completing the rest of the peeling, did a little bit of modification after doing the fluid air exchange. Gave a visco drop, gave 2 drops of the visco and manipulated the ILM over the macular hole. And the results were very good. Now, this is a situation, the macular hole associated with retinal detachment. This is a difficult situation because as there is no posterior support, the peeling becomes very difficult. We start from the nasal side. It doesn't happen. We start from the peeling ILM where it is steamed in a better way. But if that also doesn't happen, after creating a flap, we inject PFCL to stabilize the posterior pole. And once we have done it, from the peeled flap, we proceed peeling the rest of the ILM. As you can see, this is now much easier. The retina is coming, but still we have some stability. Now we have done with the peeling, and generally it is drained from another hole. And this is the last scenario where this is a failed macular hole, and this was done outside. It was done in another hospital, so we didn't know how much area of peeling was there. So according to that, we decided if the peeling was done, then we will do a free flap, or if the, as we can see in this case, the peeling was not that much, so we decided to re-peel this case from the previous margin of ILM peeling, doing an arcade to arcade peeling. The inferior part is over. Restaining is important. We need to see what to peel. Start from where it is stained in a better way and complete the peeling. In fact, this case had a favorable response. There was a closure. Obviously, it was a type 2 closure, but at least the closure, we could achieve the closure. So with the advent of the better technologies, better viewing system, we can actually predict a favorable outcome in the most of the macular hole cases. Thank you. Thank you very much.